When you hear the word depression, do you think of being sad or upset for a really long time? Because that's not what clinical depression is. It can include that, but there's usually much more. Stay tuned to learn just how much more. Mental illness is just one dimension of society and culture I make content about here at The Advocate Who's Autistic. And the name of my channel should tell you something worthwhile about the mastermind behind said content. If what you're seeing and hearing today looks like something you'd want on your subscription list, it probably is, and you should act accordingly. So what does having depression look and feel like? Clinical depression usually manifests itself as a low mood or feeling of numbness so intense it pervades all areas of life. When depression sets on, the patient often loses interest in activities they once enjoyed. Depressed people may be preoccupied with or ruminate over thoughts and feelings of worthlessness, inappropriate guilt or regret, helplessness, or hopelessness. Other symptoms of depression include poor concentration and memory, withdrawal from social situations and activities, reduced sex drive, irritability, and thoughts of death or suicide. Depression can also affect sleep patterns, resulting either in insomnia or inability to stay asleep, or hypersomnia, which is sleeping too much. Depression can seep into a sufferer's physical health, resulting in symptoms such as fatigue, headaches, or digestive problems. Now let's talk about some possible causes of depression. The diathesis stress model specifies that depression results when a pre-existing vulnerability, or diathesis, is activated by stressful life events. The pre-existing vulnerability can be either genetic, implying an interaction between nature and nurture, or schematic, resulting from views of the world learned in childhood. American psychiatrist Aaron Beck suggested that a triad of automatic and spontaneous negative thoughts about the self, the world or environment, and the future may lead to other depressive signs and symptoms. Depression can and does run in families, though it's not as likely to be inherited as bipolar disorder and schizophrenia are. Depression can also arise after a chronic or terminal medical condition, such as HIV, AIDS, or asthma, and may be labeled secondary depression. It's unknown whether the underlying diseases induce depression through effect on quality of life, social stigmas attached to certain conditions, or through shared etiologies such as degeneration of the basal ganglia and Parkinson's disease or immune dysregulation and asthma. Abusing substances at a young age is associated with an increased risk of developing depression later in life. Depression occurring after giving birth is called postpartum depression and is thought to be the result of hormonal changes associated with pregnancy. Seasonal affective disorder, a type of depression associated with seasonal changes in sunlight, is thought to be triggered by decreased sunlight. Adverse childhood experiences, incorporating childhood abuse, neglect, and family dysfunction, markedly increase the risk of major depression. Childhood trauma also correlates with severity of depression, poor responsiveness to treatment, and length of illness. Some are more susceptible than others to developing mental illness, such as depression after trauma, and various genes have been suggested to control susceptibility. Couples in unhappy marriages also have a higher risk of developing clinical depression. There appears to be a link between air pollution and depression and suicide. There may be an association between long-term PM2.5 exposure and depression, and a possible association between short-term PM10 exposure and suicide. So what exactly is going on in the brain of someone with depression? The pathophysiology of depression isn't completely understood, but current theories centered around monoaminergic systems, the circadian rhythm, immunological dysfunction, HPA axis dysfunction, and structural or functional abnormalities of emotional circuits. Derived from the effectiveness of monoaminergic drugs in treating depression, the monoamine theory posits that insufficient activity of monoamine neurotransmitters is the primary cause of depression. Evidence for the monoamine theory comes from multiple areas. First, acute depletion of tryptophan, a necessary precursor of serotonin and a monoamine, can cause depression in those in remission or relatives of people who are depressed, suggesting that decreased serotonergic neurotransmission is important in depression. Second, the correlation between depression risks and polymorphisms in the 5-HTT-LPR gene, which codes for serotonin receptors, suggests a link. Third, increased activity of monoamine oxidase, which degrades monoamines, has been associated with depression. However, the monoamine theory is inconsistent with observations that serotonin depletion does not cause depression in healthy persons, that antidepressants instantly increase levels of monoamines but take weeks to work, and the existence of atypical antidepressants which can be effective despite not targeting this pathway. Theories unifying neuroimaging findings have been proposed. The first of these is the limbic cortical model, which involves hyperactivity of the ventral paralimbic regions and hypoactivity of frontal regulatory regions in emotional processing. Another model, the corticostriatal model, suggests that abnormalities of the prefrontal cortex in regulating striatal and subcortical structures result in depression. A third model proposes hyperactivity of salient structures in identifying negative stimuli and hypoactivity of cortical regulatory structures, resulting in a negative emotional bias and depression consistent with emotional bias studies. So, what standards must be met for a diagnosis of depression? Under mood disorders, the World Health Organization's International Statistical Classification of Diseases and Related Health Problems, 11th edition, classifies major depressive disorder as either single episode depressive disorder, where there is no history of depressive episodes or of mania, or recurrent depressive disorder, where there is a history of prior episodes with no history of mania. ICD-11 symptoms, present nearly every day for at least 2 weeks, are a depressed mood or anhedonia, accompanied by other symptoms such as difficulty concentrating, feelings of worthlessness or inappropriate guilt, hopelessness, recurrent thoughts of death or suicide, changes in appetite or sleep, psychomotor agitation or retardation, and reduced energy or fatigue. These symptoms must affect work, social, or domestic activities. According to the APA's Diagnostic and Statistical Manual of Mental Disorders, 5th edition, at least one of the symptoms is either depressed mood or loss of interest or pleasure. Depressed mood occurs nearly every day as subjective feelings like sadness, emptiness, and hopelessness, or observations made by others, such as appearing tearful. Loss of interest or pleasure occurs in all or almost all activities of the day, nearly every day. These symptoms, as well as 5 out of the 9 more specific symptoms listed, must frequently occur for more than 2 weeks to the extent in which it impairs functioning for the diagnosis. So what forms can depression come in? When someone has melancholic depression, they lose interest in most or all activities, and they become unresponsive to stimuli that once gave them pleasure. They have a quality of depressed mood more pronounced than that of grief or loss, and their symptoms are at their worst during the morning hours. Melancholic depression is also accompanied by early morning waking, psychomotor retardation, excessive weight loss, and/or excessive guilt. Symptoms of atypical depression include mood reactivity, aka paradoxical anhedonia and positivity, a desire to emotional eat, leading to weight gain, excessive sleep or sleepiness, a sensation of heaviness in limbs known as leaden paralysis, and significant long-term social impairment as a consequence of hypersensitivity to perceived interpersonal rejection. Catatonic depression is extremely rare and particularly serious. A person with catatonic depression has disturbances of motor behavior, is mute and almost stuporous, and either remains immobile or exhibits purposeless or even bizarre movements. Depression with peripartum onset can occur either after giving birth or while pregnant. DSM IVTR used the classification postpartum depression, but this was changed not to exclude cases of depressed women during pregnancy. Depression with peripartum onset has an incidence rate of 3 to 6% among new mothers. The DSM-5 mandates that to qualify as depression with peripartum onset, the onset must occur during pregnancy or within 1 month of delivery. Hence its name, seasonal affective disorder, or SAD, is a form of depression in which depressive episodes come on in the fall or winter, then resolve in the spring. To qualify as SAD, at least 2 episodes must occur during the colder months, with none in the warmer months, over a period of 2 months or longer. So what might a doctor prescribe someone after diagnosing them with depression? The type of antidepressants most commonly taken by people with depression are selective serotonin reuptake inhibitors, or SSRIs. These generally work by increasing the extracellular level of the neurotransmitter serotonin by limiting its reabsorption or reuptake into the presynaptic cell. They have varying degrees of selectivity for the other monoamine transporters, with pure SSRI having strong affinity for the serotonin transporter and only weak affinity for the norepinephrine and dopamine transporters. Sold under the brand names Lexapro and Cipralex, escitalopram is used to treat generalized anxiety disorder as well when it occurs alongside depression, as SSRIs commonly do. Like other SSRIs, escitalopram works by increasing the amount of serotonin in your brain. Escitalopram usually takes 1 to 4 weeks to start working and can cause serious withdrawal if stopped suddenly, which can manifest as mood changes, irritability, agitation, nausea, dizziness, burning, numbness, or tingling in the hands and feet. Escitalopram has some side effects sometimes, including headache, nausea, sexual problems, mild sedation, and trouble sleeping. More serious side effects may include suicidal thoughts in people up to the age of 24 years. Paroxetine, sold under the brand name Paxil, is used to treat a wide range of mental disorders, including OCD, panic disorder, social anxiety, PTSD, premenstrual dysphoric disorder, and of course, clinical depression. Studies done on Paxil have shown its efficacy to be superior or equivalent to placebo and equivalent to other antidepressants. Specifically, it's closest in efficacy to venlafaxine and clomipramine. Common side effects of paroxetine include drowsiness, dry mouth, loss of appetite, sweating, trouble sleeping, and sexual dysfunction. Sold under the brand name Zoloft, sertraline is used to treat depression, anxiety, and PMDD, just like paroxetine. The good thing about Zoloft is that most users who experience side effects report them being relatively sporadic or going away after a week or 2 of taking them. Said side effects include headache, lightheadedness, body aches, and upset stomach. Zoloft can also cause you to take longer to climax during sex. Now on to some non-SSRI antidepressants. Sold under the brand name Wellbutrin, bupropion is a smoking cessation aid as well as an antidepressant. It's not an SSRI, but is sometimes taken in addition to an SSRI when the patient has an incomplete response to the SSRI. Rather than increasing serotonin levels like SSRIs, Wellbutrin works by boosting dopamine and norepinephrine levels. Wellbutrin is set apart from other antidepressants in that it lacks the side effects of sexual dysfunction, weight gain, and sleepiness. That being said, it does carry a higher risk of seizure than other antidepressants and has the side effects of dry mouth, constipation, and excessive sweating. And Lefaxine is the antidepressant I take, sold under the brand name Effexor. Effexor is an SNRI, or serotonin and norepinephrine reuptake inhibitor. It increases both serotonin levels and norepinephrine levels in the brain. Let me tell you from experience, Effexor causes really bad withdrawal if you miss a dose or suddenly go off it. What kinds of therapies are available for people with depression? Our first one, psychotherapy, can be delivered to individuals, groups, or families by mental health professionals, including psychotherapists, psychiatrists, psychologists, clinical social workers, counselors, and psychiatric nurses. With more complex and chronic forms of depression, a combination of medication and psychotherapy may be used. There is moderate quality evidence that psychological therapies are a useful addition to standard antidepressant treatment of treatment-resistant depression in the short term. Successful psychotherapy appears to reduce the recurrence of depression even after it's been stopped or replaced by occasional booster sessions. In treating clinical depression, cognitive behavioral therapy consists of teaching clients to deconstruct their self-defeating and counterproductive behaviors. CBT has the most research evidence for the treatment of depression in children and adolescents, and CBT and interpersonal psychotherapy, or IPT, are preferred therapies for adolescent depression. Cognitive behavioral therapy and occupational programs have been shown to be effective in reducing sick days taken by workers with depression. Several variants of cognitive behavior therapy have been used in those with depression, the most notable being rational emotive behavior therapy and mindfulness-based cognitive therapy. Interpersonal therapy seeks to tackle the depression symptoms of social isolation, excessive fatigue, lack of motivation, and loss of joy. Typically, there are 3 phases of IPT for the treatment of depression. The first phase involves introductory therapy sessions with the counselor and patient, in which the counselor begins to familiarize themselves with the patient's symptoms and interpersonal conflicts. Goals are then curated in order to establish a path of healing for the patient. The second phase of IPT connects the patient's presenting symptoms to their interpersonal conflicts. Specifically, this phase of treatment attempts to find potential causes for the patient's low mood. The third and final phase of this treatment begins when the patient's symptoms have stabilized. Plans are established for continuance of treatment in case the patient begins to develop depressive symptoms again. Based on Freudian psychoanalysis, psychodynamic psychotherapy assumes that a case of depression and its symptoms is rooted somewhere in the deep back levels of the brain or the unconscious. Specifically, the root cause of the depression goes back to an unconscious mechanism or way of thinking that developed very early in childhood. Common techniques of psychodynamic psychotherapy include free association, dream interpretation, and recognizing resistance. Now let's talk about the stigma around depression and how we can beat it. The stigma around depression has led people to believe many falsehoods about it. First and foremost, some people think depression isn't a real medical condition. They think it's a normal period of sadness, a character defect, or even a choice or something a person can snap out of. But it's an illness, just like diabetes or cancer, and we ought to treat it as such. On the opposite end of that, Many people who don't have depression believe that the antidepressants I talked about earlier are happy pills or that they automatically make depression go away. They definitely help, but are far from being a cure-all. Depression often requires therapy and addressing of root problems in addition to antidepressants. So don't ever assume that because someone starts taking antidepressants, their problems magically gone away. Everyone feels sad or upset at some point, but that's not what clinical depression is. When you have depression, you have a sadness or emptiness that is longer or more intense than what can be considered normal. So don't ever tell someone with depression that it happens to everyone, so they just need to deal with it. And if you yourself have depression, you don't just have to live with it. There is help and resources available, such as the medications and therapies I've already mentioned. You don't have to have something specific to you to have depression. It can be caused by anything from trauma to stress to genetics to even just flat out brain chemistry. Tragic life events can definitely be a contributing factor, but those things don't have to happen for someone to have depression. So don't just assume someone doesn't have depression simply because you don't know of anything major they've had happen to them. It is possible for depression to run in families, but that doesn't mean that everyone who has depression got it from a parent, and that anyone with depression who has kids, the kids will inevitably get depression. Overall, it's a combination of genetic and external life experiences that determine if depression surfaces. Those who have family members with depression may have a better understanding of the signs and symptoms, leading to a more likely chance of discovery. There's a higher prevalence of depression in women, and women are more likely than men to attempt suicide. But men get depression too. The discrepancy in diagnosis is most likely explained by the fact that men often don't talk about their depressions or seek help, most likely for fear that they could be seen as weak or less manly. We can defy the taboo on mental health by talking about it publicly. The more we hear it talked about, the more truths about it are known and falsehoods are debunked. One of the primary ways we break mental health stigma is through education. Knowledge is power. In schools, workplaces, and in the media, facts and experiences of depression need to be shared so that misconceptions are dispelled, kind of like I'm trying to do with this video. But before you educate others, make sure that you yourself are educated about depression, that you not only have the facts, but have the right attitudes and perspectives on it. Admit to any unconscious biases you might have and figure out what you need to do to fix your perception. Change starts within ourselves. Did you learn anything shocking about depression today? Let me know in the comments. If you like this video, let me know by giving the video a big thumbs up. If you haven't already, subscribe to my channel and tap the bell icon so you can get notifications about even more videos like this. While you wait for my next one, check out my most recent video and one that YouTube thinks you specifically would like.